Well, and welcome to week 2 of leadership. If you would go ahead and place your name and your campus in the chat if you have not done so thus far. Give you a few seconds to do that. Just as a reminder, these sessions are recorded and they are viewed by the attendance administrator. In the event that you have to walk away from the camera before break time, please place a message in the chat to myself. Do not send it out to everyone. Do not send it out to everyone. Just send it to me and let me know why you're not in front of the camera. If you're having connectivity issues or any issues, just please let me know. Place it in the chat. Just send it to me. So just go ahead and get it in accustomed to when you log in. Check your name. Make sure that your name on the screen is displayed correctly with your first and your last name, how it appears on the roster. So we go back and have to go back and do a fact check. It will show that you were here. So if you're in the middle of a name change and it has not been officially changed, list it as it is presently on the roster. So there are no problems. All right, so let's just look back at week 1 here. So we can see where we're at and where we're going. Usually after this first exam, you all, things get really, really fast. So for those of you that are, have more than one class, even just this class, just make sure that you have, been placing things on your calendar, looking and seeing what you can revise, rearrange, put on pause, and also delete. Some things you can delete. So I have someone here with the iPhone, name is an iPhone. So please change your name. You click the little dots. From my understanding, you click the little dots and it asks you to rename. Make sure you do that.
Hello, it's a Gonzo. I'm using iPhone for the quiz.
Okay, so you're logging already in twice. Okay, gotcha. All right. Thank you for that update. All right, so let me pull up our course here. Yes, traditionally we will take the quizzes at the beginning of the class. This is week 2. In the first quiz, we'll kind of adjust it as we go along, but generally when you come in, that's gonna be the first thing that we do. But let's just look and see where we're at. So we're still getting adjusted here. Let's see. Let me share my screen. Okay. All right. So let's look at our what we said we're supposed to cover last week. Minimize us here. So we're looking at the vocational nurse from 1836 up until present. Let me just make sure we're recording. So some things have changed since then. And that's from chapter 4 and chapter 12, the nurse's role. So because initially the LPN wasn't recognized as an important person of the healthcare team. But as things advanced and as people, broaden their understanding and understood what we could do as nurses, the LPN role, it was recognized as being just as important and just as valuable as any other healthcare team member. So the National League of Nursing did recognize, hey, the LPN or the LVN is an important person on the healthcare team. And as a result of that, the pay increased. So the salary of the LPN and the RN narrowed because of that. Because once they realized, well, hey, this person is certified, they are credentialed. And so that came with an increase in pay. So as a result of that, the salary gap between the LPN and the RN, it narrowed. The LPN began to get paid more money. And also, because initially, because nurses, the LPNs were really not recognized as an important part of the healthcare team, there were only certain amount of slots available for people that were interested in becoming nurses. That in itself created a nursing shortage. And we are still trying to catch up as of 2025, April the 1st, April the 14th. And so as a result of that, nursing programs have been redesigned. Initially, it was Monday through Friday, brick and mortar, sit in the classroom, business hours. Now there is a variety of nursing programs. There is hybrid, part-time, full-time, nighttime. You can have online classes as well as in-person classes. There's just a huge mix. There's even, as many of you all mentioned in your first discussion question, you chose a program because of the accelerated program that they had, the ongoing admissions. There are some nursing programs that still exist. They only admit like that one time a year or that twice a year. And so nursing shortages contributed to the change in nursing programs. As a result of that, we have all of these different options. And most of the LPN is valued as an important part of the healthcare team. And as a result of that, the pay increase. So they could never pay us our worth, but it did increase. So as a result of that, the salary actually was narrowed. And so there are some terms that they've come up with. They're just four terms that they've come up with as a whole, as all the things we do. Just think about all the things that you have done in the skills lab, all the different settings that you've been in, the various clinical settings, all the things that the tasks that you've completed. They summed it all up in four terms: determine, appraise, judge, and recognize. So just think about the S bar. Think about the nursing process. So those terms again are judge, appraise, recognize, and to determine. Those are the terms that the U.S. Department of Education has used to just describe the scope of nursing as a whole. They had to narrow it down, and so those were the four terms that they used. Okay, so that's that's a little bit about our history here. Let's look at chapter 4 PowerPoint. We went over chapter 12 last week. And let's see that we get everything here. So in the chat, I need each person to list at least 3 things that changed for nursing in the 21st century. Now I'll give you a few minutes. I'm looking here just to make sure I've covered all the high points here. So in the chat, and you can send this out to everyone. I need you to narrow down, paraphrase, put into your own terms the things that I've talked about regarding the changes in nursing since the 21st century. So I'll give you a few minutes to put that in the chat and send those out to everyone, your responses. Okay. We know Florence Nightingale's very influential. We all have learned about her. Okay, the Crimean War. Okay. So I'm waiting on your responses. I don't see any popping up just yet. So you can put it into your own terms. And I will stop and pause to read this slide right here. Nursing, is a calling, it's a commitment. We spend most of our time with our patients. Our families, you hate to say it, but a lot of depends on what setting, which pathway you go, they come second or third or fourth on the list. So it really is a calling and it's a commitment for service to humanity, for mankind. No matter if they are insured or uninsured or have insurance, we still provide the best care we can for every person that is that's put in front of us to take care of. All right. So we're going to talk about the different settings here in a moment, the long-term care settings. Let me just pause here and look and see what you are placing in the chat here. So so this right here, that 21st century, it kind of started in the 20th century. They recognize these and begin to say, hey, these people, we're just as important. Okay, let me stop and see what you all are saying. So the task was in the chat, I needed you to summarize 3 things that have changed in regarding to nursing over the 21st century. I see pay rate for everyone. So the pay rate. So as a result of that, the salaries between the LPNs and the RNs narrowed. Okay, there was a change in pay. Okay. So what did I don't see it in here. I don't see anybody mentioning, what did I say about the nursing programs? And someone can come off mute and paraphrase what did I mention about the nursing programs.
That we got more variety as
Is that
far as flexibility, whether the program gonna be accelerated,
okay?
etc.
That's great. That's number two. So we got number one. Everybody has a pay rate. So the nursing programs changed overall. The programs
Okay, man.
themselves changed.
Excuse me, man, please. I can. Have we started the quiz?
No, we haven't started the quiz.
Okay, okay, thank you.
No, we're going to do that later on. We're going ahead and catching up from week one, making sure we understand those concepts. So we had the pay between the LPN and the RN, they changed. Then we said that the nursing programs changed. That helped. It has helped with the nursing shortage, even though we're still in a nursing shortage. And what is that other thing that I said about LPs? I don't see it in the chat. What did the National League of Nursing do for LPNs? What they say about them? What they say about us?
That we just as essential as an RN.
Exactly. So you need to know those things that we just went over. Okay, good. So then I mentioned four terms. What were those four terms that I mentioned about the United States Department of Education using to describe our scope of practice? All the things we do from A to Z, headed to assessments, we administer medications, we hand off report, we call physicians, we call in lab results, we are charge nurses in long-term care facilities. What are those four terms? Did anybody catch those four terms that I mentioned? They summed up everything we
Recognition,
do. Okay, you said recognition, and what else?
judge,
Determine.
appraisal, and
Judge,
determine.
determine. What was the other one?
Appraisal and determine.
Appraise,
Praise, judge.
recognize,
Okay,
determine, judge,
recognize. That was the one I think I wasn't hearing. Yes, so recognize. So we got recognize, we got judge, and Angelique put them out to everyone in the chat, and Battle did as well. Judge, praise, determine, and recognition. So they summed up what we do. And you, as you think about all the different things we do, it falls under one of those categories. All right, so let's see where we're at now. We are finished with week one and week two. I mean, week one, I'm sorry, you all, chapters 4 and 12. We haven't finished with week two yet. All right, so now let's go here to week two. Let's look at this. All right, so now we're going to be talking about effective communication. Let me share my screen here. Share my screen. So effective communication, and then assertiveness, and all the people that are on the healthcare team. What are their roles? What do they do? Okay. Let's go over here to week two right here. And we're gonna do a little some activities here, but just want to make sure we go over our content. It's gonna seem like it's being repetitive, but I need you to be able to, just give it back every time. Paraphrase it, make the connections, and therefore, no matter how it's asked or how you see it, you're able to respond. All right, let's see here. Communication. So, we do have a sender and a receiver. And sometimes things that we send, or sometimes things that we receive, sometimes it gets jumbled up. So we do want it to be clear, our communication, because we are leading the way, and we're the gatekeeper, we're the lifeline, or all those terms that people put out there between our patients and the physicians, the healthcare providers. So with knowing that, we need to think about what affects communication. Situational. If the patient is in, just think about the hospital setting. What do we normally hear? It's noisy, it's distractions everywhere. So if someone is in pain or someone is have soul or incontinent, they had an incontinent episode, you come in, the nurse comes in, and we're trying to do some teaching, reinforce teaching. That patient is not going to pay us any attention. Yeah, because they're distracted about what's going on in the environment, the situation. So that's situational influences. And it really does. Just think about when you're trying to concentrate or you're trying to do something. What are those things that affect communication? So our age, our gender, income, and life experiences, all of those things have a play. So if we are talking to, if our patient is 5 years old, and of course, they're going to be accompanied by an adult, whether or not that adult is, grandparent or guardian or a parent. So, but the information that we are giving, if we are reinforcing that teaching, how should that information be conveyed? How should that information be given to that parent? Because remember, we're not really going to give the information to the child. But if there are some things that we can, think about a child that's 5 years old. What information or what format should that information be put in? Pictures, maybe even a video. Even someone that has issues or problems or have low literacy, we may even want to think about, well, how can we may use, the reinforcement teaching about whatever the concept is for a child. But if a person is on a fifth grade or sixth grade level, then reading level, then we may want to use some of those same resources because we do want our patient to understand whatever it is that the information we're trying to give them. We want to talk in layman's terms. We want to put it into terms that they understand because otherwise communication is not going to take place. We've just gotten up there and did a whole bunch of talk and given them some papers, but then they don't understand it. So then that person doesn't stand a chance of even managing their care because they don't understand what we're saying. We do already know that personal space, some touching, like patting on the shoulder, something, eye contact, sustained eye contact. Some of those things are offensive when we're trying to communicate, but we will learn going forward with, different cultures, about practices that are acceptable and things that are not. But for sure, situational, that environment, if there's noise, if there are odors, any type of distractions, then what we are communicating more than likely would not be communicated. It would not go over well. We need to know the difference in verbal and nonverbal body language. So give me an example in the chat. Put an example of nonverbal body language. What are some things that people can do that are not verbal, they're not speaking, that can still let you know that they are hurting, that they're in pain or in some type of discomfort? So in the chat, drop a word or a phrase, something that you will see, that you might hear, that will indicate that person's in pain. Let me put it out to everyone so everyone can see. So let's see. We're talking about verbal versus nonverbal communication. And so I'm asking you for an example. A person's in pain. What are some nonverbal things that we might observe or assess and find that indicates that person is in pain? Crying. So think about things that we will see. We may even hear crying. We may see those facial grimacing. They may be grunting, clenched fist. They're bracing. The stomach is hurting. They're bent over. So yes, good. So when we are reading, let me give you a test taking tip. So of course we know verbal is verbal. A person is speaking and saying what they want us to know. So as you're reading through your questions, make sure that you are answering what the question is asking you. Okay. That's just, and they'll come out every now and then. They'll just pop in my head to tell you. So what did I just say? Test taking tip. Make sure if you read through the scenario, make sure you're answering what the question has asked you. Because a lot of times they have this story and all these things going on, but that question is only about one piece of that entire scenario. So make sure that you are answering what it's really being asked about. Okay. Okay. You all did really good with the nonverbal. So nonverbal and verbal and affective communication. Spoken word is powerful. Nonverbal communication is powerful and can both support or cancel the meaning of verbal communication. And then it helps you to identify if you need to go back and reteach. The patient's motioning their head up and down. Generally, we understand that as to be yes, if their head is motioning up and down. But then we ask them to, perform a task and they're sitting there so they don't understand us. But remember, they motion their head up and down. So then we may have to go back and reinforce the teaching, the initial teaching that the RN actually did, because there's a mismatch. If they're saying yes, but then why aren't they performing the test? So we may need to go back and reassess things and see what we need to do differently. We want to be sure to implement all strategies to ensure a minimum impact to nonverbal behavior. Affect refers to the mood, or the emotion. And so we do want to, that's part of taking care of your patient. Make sure you always assess for that, because that person can be calm and cooperative. But then if they're withdrawn and not participating, then that's a clue that we may need to ask open-ended questions, dig further and ask more questions to see what's going on. An example that comes to mind is a patient that normally goes to, we'll just say bingo, because bingo is big business. They're playing bingo every Wednesday, but we've noticed the patient or the resident or the client, depends on what setting you're in, is what term they use, has stopped going. So we know that mood has changed. Usually they're outgoing and they're the first ones up there. They're assisting others, but then they stop. So then we want to question. They don't verbally tell us that something's going on, but that nonverbal cue of that mood and that emotion changing will clue us in to say, hey, we need to see what's going on, ask some open-ended questions and find out more. Another example could be a patient eating. You've noticed that they aren't eating like they used to. Breakfast was their favorite meal, didn't leave anything on the plate. And also you've noticed that their weight has changed. And so the patient doesn't tell you that they're not feeling well, or, they've lost their appetite. And we notice that change. So that's a nonverbal, but that mood and that emotion and that behavior has changed. We might have to also bring in what person on the healthcare team can help us with a person that's having issues with their food or their meals. What healthcare team member?
Dietitian.
Dietitian, exactly. So we're going to talk about, others on the healthcare team. We're that main point of contact, but start thinking, well, what else? Who else? Yeah, so that person, and then going back to that activity, who else can we bring in to just reassess and make sure the activities is okay and that person's not having any issues with performing that activity?
Speech therapy.
Who else?
Occupational
OT
therapist.
and PT.
Okay.
Social worker.
Okay, social worker, the activity person, even all of those therapists, because that person, and no one mentioned optometry, because even though they're in a long-term care facility, they still see the dentist, they still see the eye doctor. Their vision might have changed. Their mobility might have changed. Their range of motion might have changed. So just be thinking, okay, well, they're not verbally telling us that something is wrong, but because of these nonverbal things, their mood, their emotions have changed, then that clues us in something's going on and we need to probe further. And then thinking beyond that, we might have to bring in who on the healthcare team, the dietitian, the speech therapist, the activity director to reassess. Good. Okay. So some nonverbal behaviors, they yawning, arms folded. I think we got this one, not making eye contact. Usually people will make that brief eye contact, but sustained eye contact is kind of frowned upon. But not making eye contact at all is a nonverbal cue that something, that person might, have something, or be shy, or they may have something they want to tell you, but they just really don't know how. Looking bored, fist or clench, checking emails or on the cell phone while you're in there doing your reinforcement of teaching. And we need to make note of all of these things. All these things needs to be part of our documentation. reinforcement of discharge instructions being provided, patient checking emails and on the cell phone. Just make sure we, show the picture of what really happened. Okay, so we're going to have a little activity a little bit later on with these active listening behaviors. And so let's just look at each one of them. Let me just make this slideshow so you can see this from the current slide here. Okay, so restating, and some of these kind of almost sound the same. So just go ahead and make note of how you can tell the difference between them. But restating, we're repeating what the client said in a slightly different way. Okay. But then paraphrasing, aren't we repeating or restating? But the difference is we're expressing in our own words what we think what the client actually means. So restating is repeating what the client said in a slightly different way. And paraphrasing, these are the two that I think people most get mixed up with. But paraphrasing, we're expressing in our own words what we think the client actually meant, what the client means. Okay. Clarifying, asking questions in a response to a client statement to be sure you understand. And then reflecting, we put it into words the information that we receive from the client at an effective communication level. Okay, so putting it so they can understand. And this one right here, we forget active listening. It is therapeutic. It is okay to just be quiet. For example, if we have a patient that may have just gotten a diagnosis, the patient and their family members may have gotten a diagnosis that was not so favorable. They may have just lost a loved one. And we want to go on. The next steps is to identify. You all, I'm at the pause for just a moment. I'm hearing noises that I shouldn't be hearing. Let me just make sure my doors are. Family members may have just received some information, a diagnosis that's not so favorable. They may have even, the loved one may have just passed away. And, we're trying to, do our next thing, go ahead and notify the funeral home, make that phone call. And the family, they're just not ready to do anything. So what do you think we need to do? You think we need to go ahead and just give them that information or just remain silent?
Just give them a minute to let it process.
Exactly, Amanda. Exactly. That's right. Remaining silent. It is active communication. It is therapeutic. It is okay to just be there, just be present and be silent. Summarizing, stating the main data that you have gathered. And you're just calling out those main points. You're not going all, down in each point. You're not giving detail about each point, but just those, those main 3 top points about what you heard. And then validating. This allows the client to correct any information that you summarize. You go over, okay, well, let me make sure I understand what you said. And you call out, go ahead and state whatever. Now, if I misstated something or said something incorrectly, let me know. So that's validating, having that patient or that client to correct what you're saying if you have, misstated something. Because a lot of times when we're communicating, the receiver or the sender, lines get mixed up, and what we hear is not what was actually conveyed. So these active listening behaviors, it helps us, by restating, paraphrasing. Okay. Open-ended versus closed-ended question. So open-ended is considered therapeutic communication. And so it allows for more information. It allows for that patient, that client to tell us more. Now, closed-ended question, what are those answers usually? If we're asking a closed-ended question, what are those answers usually? 1 or 2 words. It's either this or that. If it's closed-ended, it's either yes or no.
Yes or no.
Yeah, yes or no. We're not going to get all these other details. So that's how you can kind of tell the difference between a closed ended question, and an open-ended question. That closed-ended, you're not going to get any other details. It's yes or no. But open-ended, The person will be allowed, the way it's asked, you can gather more information. Focus questions provide more definitive information. It is, for example, the patient said that their stomach was hurting, or they said that let's go back to our two patients. The one that wasn't eating the food, we asked, well, hey, I noticed that you didn't eat, your favorite meal for today. Let's see, an open-ended one is it something else that I can get you? Is there another meal choice that you would prefer, or is there something going on with the food or your teeth? Well, asking about something going on with your teeth, that's kind of closed. That's closed-ended because they're gonna say yes or no. But is there another food option that I can get you? Because they may open up and say, hey, well, yeah, if I can have, I've gotten tired of eating this, and then can you bring me this right here? And then that may lead to more information. It's more focused, and they'll give us more information. Okay. So let me go back. Let me back up to no, we haven't got that yet. Let me keep going. Okay. So positive communication behaviors. I am encouraging positive communication, developing trust through openness, honesty, integrity, and dependability using I messages. You want to establish that eye contact, but not sustain. There's a difference. You want to keep your promises. That patient put the light on, you go answer that call light, and you say they want some ice in their water pitcher. You don't come back. So then we have a complaint. So in order to avoid that, we need to keep our promises. Even if we can't go back with that water pitcher with ice, refresh, send someone else, ask one of the other team members, hey, I got this going on. Do you mind, would you, refresh this person's ice and get it back to them? Because then they're going to think that, you're not trustworthy. So we want to use that open communication, and we want to be aware of our own body language. We're doing a dressing change, and yes, they may have an odor, but we want to we want to make sure that we're not frowning and making up sounds and gasping for air and things like that. So we want to be aware of our own body language. So here we go with negative communication. Be careful with this one right here and we're just trying to, help everybody and do what we can. But the patient's going to ask you, well, what do you think, nurse? What would you do, nurse? We don't give advice. We want to make sure our patients, our clients, our residents have enough information so that they can make that informed decision. So we don't give advice. We can say, well, hey, are you having problems making a decision? And if so, I can ask the doctor to come back in and go back over that information with you again. If you're having problems making a decision, I can have the dietitian to come back in and talk to you. So why questions? Belittling, false reassurance. Everything is going to be okay. Probing. We're asking information that is not even relevant to the care that we're supposed to be giving. We have a coworker that's asking, that they had the patient when they were in the emergency room, but now we're taking care of the patient on med-surg, and they're asking us questions. Or you might have a family member that's asking information, and they're probing. So that's negative communication, and we don't want to violate HIPAA. And we don't want to judge. We have a patient that may come back, we're working in the emergency room, and they may come back towards whatever time of the month when they may have run out of their medications. But yet and still they want to manage their diagnosis, but then they've run out of their meds, so they come back. A person that's uninsured, a patient that comes in and they may be a known alcoholic or a known drug user. We don't pass judgment. We still provide that best care that we can for our patients. So we always introduce ourselves. We want to use layman's terms. We're healthcare professionals, so we're studying hard to learn these terms. So just imagine someone that's not even in nursing school. So if we use all of that nursing terminology or jargon, they're not going to understand what we're trying to tell them. They're just not going to understand. And remember, the fear of the unknown, that's just a real thing. Personal factors. Environmental factors. We talked about situational. That patient may or may not pay us any attention if we're in reinforcing education. If they're hurting, if they have all these sounds and alarms and everything going on. So this is just a picture that shows communication with instructors and staff. You know, it's an ongoing cycle. One thing does depend on the other. Okay. Brings us to this S bar. We need to know about the S bar, you all. You all tell me, what is situation? In the chat, let's use this chat and send it out to everyone so that everyone can see it. Because what happens is, even if we're not trying to remember it, which we really are trying to remember and gain a great understanding, it will help us, because we can all say the same thing, but if we say it a little bit differently, then sometimes things just connect better with us. So in the chat, tell me or give me some examples of some information that will follow up under situation. We're going to look at each category here in just a moment. So, as a matter of fact, just go ahead and do situation for right now. Situation. What isn't some information that we will give? Let me stop sharing so I can see what you're putting in the chat. And everyone, please respond. Okay. Why are we calling? Okay. The situation. Usually what brought them in. Okay. And then, so with that, we give, of course, who we are and then who we're talking about. And then we tell what is going on with the patient. The reason, our why. Just making sure I'm not missing anything here. I'm referring back to my little notes here. Okay, good. Okay. What's the patient doing for the moment? Okay. All right, so let's go back to our chart here. So we have background. So what falls under background? And for this one, let's just come off mute. Let me have 3 people to give us information that will fall under background.
The patient's history and
allergy, medication.
I hear
vital-
history. History can include any diagnosis, any surgeries that person has had, allergies. Did I repeat everything that you all said? Okay.
Vital signs, medication.
Okay.
Do admission go under background?
Well, if they've had some previous, if they've had some previous right here, under situation, of course, we're telling who we are, the patient we're calling. Patient in room 201 was admitted, April 13th at 11 o'clock. That's just some of the situation, right? Because you want to bring to their attention who you're talking about. But then right here, if they had like some previous admissions, like this person has been readmitted, this person has been transferred from med-surg to ICU, this right here gets a little bit more detail. Okay.
Okay.
What about the assessment? What is that?
What you think is going on?
Where we get our assessment
on the data?
from? Based on our data. What data? Those 2 things, like S and the O, the subject and objective data. So that information that you have gathered. So let me pause right here. All right. So nausea, is that objective or subjective? A person complains of nausea.
Subjective.
What is body odor? We know that the patient has a body odor. Is that subjective or objective? We check the person's temperature, and the temperature is 97.8, it's 100.1. What is that? Subjective or objective?
Objective.
Okay. We see what their orientation level is. We ask, purpose, where they are, and they're oriented times 4. What is orientation?
Subjective.
Objective.
Objective is objective. Okay. What if they rate their pain as a 5 on a scale of 10, 0 to 10?
It's subjective because it's what they said.
It's subjective because it's what they said, the subject. Okay, got it. So we got those. Those are some examples. You all did really well with that. So let me back up. If we get a abnormal blood pressure, an abnormal temperature, an abnormal finding, we check the pulse, it is abnormal. What should we do before we go on and report that information? What do we need to do first?
Go back and reassess.
Repeat it, recheck it. Got it. Y'all are on it. Okay. So let's move to the recommendation part. Recommendation. What's going on there?
What should happen next? Like your recommendations of
goals and outcomes.
What should happen next? The goals of the care, orders that may need to be addressed. Good. Procedures that might need to be done, or any other information that should be reported. Okay, we got that. Good. All right, let's see, how do we do the SBAR? How to use it if we're calling a physician. Okay, and then it's a little different if we're just handing off to our coworker. So the situation, what is the reason for the call? Include your name, the unit, the client name, and the problem. Background, admitting diagnosis, the date of admission, the current information, their vital signs. And if you're calling about if the situation is the vital signs, so you may say it twice. Well, I'm calling because of blood pressure right now, or at 10 o'clock or at 8 o'clock was this. But then part of the background, we do want to give what it was previously. So some things may fall in both categories. Background, we want to say what they're allergic to. What is that cold status? We need to know that. We need to know that of every patient we are assigned to. We need to know, because you just never know when a patient will be without pulse, and we have to decide, is this patient a full cold or not? What do we do? Well, we need to know that cold status. Assessment, what you think is going on based on the data findings. We will collaborate with the RN as needed. For example, is this problem life-threatening? And then recommendations, goals of care, what needs to be done, including consult, the next medication order, or that patient may needs to be transferred. Okay. So this is, we're handing off. So it's similar. We have that mission date. We have that mission date here. Remember, for the physician, we have, do we have a mission date on here? Oh, we did. And so it's not on here, but we can include that though. But we're just handing off mission date, chief complaint, and then that diagnosis. We'll give that background, include their code status, any lab results, their vital signs for the assessment, pain assessment. We're always assessing pain, and we're always thinking about, environmental. Are they at risk for falling? Any medications that were prescribed? And then recommendation is still the same. Goals of care, what needs to be done on the next shift. I gave Tylenol for the fever that they have, and then we're changing shift, and I'll give a report to you. That patient's temperature can be rechecked in 4 hours, and if needed, they can give some more medication. So that's something that we will bring to their attention. Education and discharge instructions, we can reinforce. So communication across the lifespan. So just remember, going back to that test taking tip that I gave you earlier, consider the age, the lifespan when you are reinforcing. You're not going to change the information that you're giving, but it may be the way. You might have, for a child, there might be toys involved in order for them to understand or be receptive to what you're teaching. And then so just consider the age, the lifespan. So email etiquette. Determine whether or not email is the best way to send your message. Consider the content. Skip a line to separate topics. Avoid using inappropriate language, and make sure, we don't use the what are those things called? Those letters that we use. Y'all know what I'm talking about. But they mean words, but so make sure that you spell out whatever it is, because depends on who you talk to, certain letters mean certain things. Because one of the things that they say all the time, like, what are you doing? But they have a why there. It's like, well, but anyway, so just make sure you're writing out things so that there's no miscommunication when you're sending an email. We want to use that appropriate language. We don't want to use anything that's inappropriate. Okay. And so keep your sentences and everything just short to the point. Short to the point. If you need to follow up in person, say so. Hey, this is just a prelude to our conversation that I wish to have, later about whatever the topic is. Because then those emails, you can't include everything, because then they'll just be long, long, long and exhaustive. And then they might not read it. So you might want to just keep it short to the point and then ask for a in-person meeting later. So when we are charting, please take the time to document. Make sure what we're writing is accurate and factual. Making sure if we read what you're saying that we can actually visualize it. Don't say assume, it appears. Use descriptive terms so that we can clearly, if it's a rash, if it's on the right arm, the lower arm, front, back, if it's round, if it's square, use standard measurements or standard shapes and things like that to describe it. Make sure it's clear and concise. So, of course, other types of communication, cell phones, text messaging, social media. In this conflict resolution. So many times you might even be on the committee. They have these committees at all of these healthcare facilities to help resolve conflict. And conflict can come from anything. It could be nothing about the care that you provided, but then it may start off being about the care you provided. But what it really was, that patient got a bad diagnosis or a diagnosis that wasn't so favorable, but then they turn it to something, they react on us saying it was something that we did. But conflict resolution, we do want to gather all the information, because we have to see, what really is the issue. We might even have to go back and get 3 shifts information. If they're saying that something happened over time, as far as the direct care that they were received, we may have to get that information, get written statements. And so be sure that no matter our check-in and check-out procedures for visitors, making sure that we're following those in whatever facility that we're in, because sometimes those logs, that's that verification that can say, well, hey, this person, you said your family member had 10 people that come in and they brought him or her gifts. We don't even have anybody registered for this whole week as coming in to see your loved one. And so make sure that people are following those standard procedures. They may seem not that important, but if something comes up, some type of conflict comes up, then you have to go back to those things, those procedures that are in place, those written documents, and review them, and to validate or disvalidate what is actually being allegated. So respect one another, even though there might be conflict. Even like when we go off into small groups, you all may disagree on something, but we do want to be respectful. And then we want to stay away from name calling and blaming. I got my little timer on here. We still have about 10 more minutes before we go on our first break. All right, so let me pause now. Let's go over some content here. Let's see. So I'm going to pause. Are there any questions about anything that we went over thus far? We talked about subjective, objective information. We talked about nursing, the 21st century. We talked about these words that the United States Department of Education came up with to describe us. It came down to 4 terms. Isn't that something? All that stuff we do. Are there any questions about anything that we went over so far? Any questions? Any questions? All right. Let me check the chat just to make sure. Okay. All right. So let's go ahead and let's do a little interactive game here. Let's go to Kahoot. I have one pulled up here. I think this one only has 6 questions on it. Let's do this one. Let me host a live. And the code is coming up. So I need you to go to Kahoot.com. This one only has 6 questions, and it'll take us on into our break. Let me share my screen here. Kahootit.com. So log in at least with your initials. You don't have to write your whole name, but if you can, that's fine. If you'd like to, but just go ahead and log in. All right, let's get started here. Let's start putting it. Okay. What are some characteristics of nursing in the 21st century? Okay. So yes, those nursing programs, they changed. They're all different, different programs, hybrid, part-time, accelerated. The salary gap between the nurses, they narrowed because the NON, the National League of Nursing, recognized that the role of the LPN is just as important as anyone else on the healthcare team. That was one. And as a result of that, it automatically led to this increase in pay. So what are the phrases that are used, phases of the nursing process? Okay. All right. So remember ADAPI. So just as you read through your questions, your scenarios, just consider, what information would I be assessing? Use ADAPI to guide you. Okay. Which part of the nursing process does reinforcing follow-up information address? What part of the nursing process when we are reinforcing follow-up information? So what are we talking about? We are reinforcing something. Reinforcing follow-up care. That is that teaching and learning. So we have went in and we've taught, we went over information, and we want to ensure that they have learned. So that teaching and learning. And that could be, person's getting ready to be discharged or going home. They were there admitted for pneumonia. Person just had some type of surgery. Doesn't matter. That teaching and learning, that discharge information, that follow-up. We want to make sure they follow up like they're supposed to. Can LPNs be a charge nurse for a long-term care facility or agency? LTC, long-term care. Can we be charge nurses at a long-term care facility? Okay. So, yes, we can. So let me ask the reverse of this. Can a LPN be a nursing supervisor at an acute care facility? And you can just come off mute and say yes or no. Can an LPN be a nursing supervisor at an acute care facility?
No.
No.
Okay. Can an LPN complete admission assessments?
No.
Can we deliver discharge instructions?
Yes.
No, I don't think so.
No, we reinforce
No.
it.
We can reinforce, but we don't deliver those discharge
Right.
instructions. Okay. Good. Okay, what are the phases of the nursing process? Does the LPN function in a more independent role? We're not saying that they're independent practitioner. What are those phases where the LPN function in a more independent role? Think about what we do, what we in the skills lab, we do what we do. Well, think about clinical. Trying not to give you the answer, but just think it through. So yes, we LPNs, we're not independent practitioners, but we function more independently. When we go in and do our head to toe assessment, we collect our data, and then we're in there, we're administering medications, we're doing that wound change, we are inserting that Foley catheter. These two parts. Okay, good. So, do the LPN formulate the nursing diagnosis, or do the RN formulate the nursing diagnosis?
RN.
The RN. RN.
Okay. What are the phases of the nursing process does the LPN function in a more, this one says, dependent role? We just talked about independent role. So we know they function more independently with assessment and collecting data and implementation. This question is saying more dependent. Okay. So then it would be the planning and deciding what to do. That's that nursing diagnosis, and then evaluating, did this work, or is the goal met or not met? So again, that test taking tip, well, it was asking us about the nursing process, but then let's see, what is it asking us about the nursing process? It says, well, the LPN, how do they function in a more dependent role? The other question said more independent. So make sure you're answering what it's actually asking. So take the time to read through. You have the 15 minutes to take the quiz. You have the 75 minutes to take the exam. Okay. The LPN does create a nursing diagnosis. Is this true or false? Okay. This question is false. Remember, we just said that the RN creates that nursing diagnosis. Okay. All right. Was that our last question? Okay. One more. The LPN can be a supervisor in an acute care facility. Okay. So we just said LPNs can be supervisor in long-term care facilities, not acute care. Okay. So yes, be sure that you are answering what the question is asking. So don't read through so fast so that you don't answer what is being asked. Let me turn this thing off here. All right. And so we didn't talk about assertive behavior. I don't know if I covered in this other Kahoot or not, but assertive behavior is, it is therapeutic. It is positive communication. It is stating things that are, that's our little thing. It's time to go to break here. So we're going to pause so we can stay on task, and we'll pick it back up when we come back. So see you in 5. At a minimum, just sign in with your initials. You can put your name, but your initials will work. Let me pull it up here. Okay, it's loading. And here we go. Let me make sure we're recording. Yeah, we're recording. Okay, log in, www.kahoot.it 714-515. All right, let's go ahead and get started. Role and responsibility of the LPN. So here it is, we're talking about a nurse, but it's specifically saying the LPN. So is this true or false for LPN? Is this true or false for LPN? Is this correct or incorrect? Is this correct or incorrect? And you can actually look at, you can, as you read your answer choices for any question, another test taking tip, you can say, some people like the words true or false or correct or incorrect. So once you've identified and narrowed it down to what the concept is this, as you read each answer choice, is this correct or incorrect? Or is this true or false? And then that will help you. And remember, it has to be, the answer choice has to be all the way correct that matches that concept in order for you to select it. So if you read an answer choice, you're like, well, they can do this part, but this part doesn't match, then that's not an answer choice you want to select. Okay. Good. So why is it not initial discharge instructions? What word would make this true for us, the LPNs?
Initial.
Reinforce.
Reinforce. Initial is what is incorrect. We don't do the initial discharge instructions. We reinforce. Okay. What would make this correct for us or true for LPNs?
Long-term care facility.
Got it. Good, good. So that was a test taking tip too. As we read the answer choice, we're like, well, I know that this is right here is true for us. So this doesn't match. Okay. What part of the nursing process do this information belong? Discharge instructions from the emergency room. Okay, good. So teaching and learning. Those instructions, we're giving them information and we hopefully they learn it. We're teaching, reinforcing, and we hope they learn it. Which part of the S bar, we just went through each part. Which part discusses patient's goals? So think it through. What does the S stand for? What does the B stand for? What does the A stand for? And what does the R? Situation, background, assessment, and recommendation. Now, discuss patient goals. Which category does it follow under? Ooh, y'all are rocking. Good. Which part of the S bar again? Which part? Situation, background, assessment, or recommendation. We're talking about this person, the patient has a change in their mental status. They have decrease in urine output. Situation. It is situation. That's why we're calling. Person had a change in their mental status or they had a decrease in urine output. It went 8 hours and they didn't, which that I can see why you all may have put it as part of the assessment, but it's generally why we're calling. Okay. And then when we get to the assessment part, we can say, well, hey, they initially was alert oriented ×4. Now, they only know that who they are. Each member has a part or a function that they fulfill on the healthcare team. So we talked about the dietitian, the therapist, the nurse, and so that means that care is divided. That is true. Patient-centered care is. It did not say patient-centered care is not. It's saying what it is. So which of these is true? And this is supposed to be a C, respectful. Which of these are true for patient-centered care? Okay. Respectful. The actions are dependent on what the individual needs. We'll talk about these care plans in a minute, how we get these standardized care plans, which every option is there, but we have to come in and take out the things that do not apply to our patient because we want to provide patient-centered care or individualized and make things individualized. Okay, good. So This one, be sure to read and make sure that you're understanding what the answer choice say. We don't want to be disrespectful. We want to be respectful. So just make sure that we're taking the time to read and answer, making sure that we select the correct answer choice that we mean to select. Because I don't think we meant to say being disrespectful. But that's how some answer choices will be similar. And if you don't really read it, then you'll end up selecting the incorrect one. All right. Sexual harassment is, so which of these things matches or is true for sexual harassment? Or as an example, something that matches sexual harassment. Okay. So we did not say a luncheon plan for the department. So, because that's for everybody. But if we start singling out one person, and then that is sexual harassment. Because if we are at work, it should be for the entire department. Unwanted sexual references and making jokes. All that is considered sexual harassment. True or false? Or correct or incorrect? The LPN initiates teaching. Okay. Good, because we said this one word changes it here. We can teach, but we reinforce. Our teaching is reinforcing. The LPN and the RN formulate the nursing diagnosis. Okay, and it is false because the RN formulates the nursing diagnosis. Let's see, active listening. Let's talk about this active listening. We went over all those different forms, things that we can do. Okay, so we do want to ask questions just to make sure that we have, that we understand correctly. We can paraphrase what we think we've heard, so they can come in and validate it. And then we always allow the person to speak uninterrupted. Okay, good. Two more. Communication involves nonverbal cues. Is this true or false? Is it communication, or does communication have to be all verbal? Okay, it does include nonverbal. And our last one, here we go. Communicating with others directly and in an honest manner, without intentionally hurting anyone's feeling is being assertive. So we're providing information that is honest, that is, that is for the betterment. We need to turn, you do need to turn every 2 hours, at a minimum every 2 hours. This will prevent you from, getting, having your skin to be torn. It decreases the chances of your skin being torn. Getting out of the room, going to activities, or letting the activity department know about activities, and being sociable, that could help. And these are just some examples that I'm throwing out. So yes, but those are examples of providing that honest information. We're not trying to hurt anyone's feelings, but we're being honest, and we're clearly communicating. Now that's different from being aggressive, saying something that is disrespectful. All right, I think we read. Are there any questions about any of the content? I already clicked on it. I need you to refresh, because what's going to happen is you're not going to see it. And I am going to, and I'll put the time to return in the chat. Once everybody's gotten started, I put a return time, but it'll be 15 minutes. Code is out, and I'm going on mute.
I'm sorry, it still shows as locked for me.
I need you to communicate via chat. Perez, thank you so much. That's what I was doing. I forgot that I was on Pacific time. I was actually on Central Standard Time. I was all over the globe. Thank you so much. So that's what was wrong. But yes, always use your chat because things become chaotic. And then so just use your chat and just stay focused. So let's see, how did we do? So for the math problem, I think everybody got that one correct. If you missed it, remember the test taking tip that I asked, that I mentioned? Answer what the question is asking you. It said to round to the nearest 10th. So if you did not, if you missed that, but that was an example of answering what the question asks. So just be sure that you're with those math questions. Sometimes it'll ask you to round to the nearest whole number, to just make sure that you're asking. Miss Lawson, yes, ma'am. It won't let you come off mute. Your hand is raised, Miss Lawson. It won't let you come off mute. Okay. Well, I'll go on. And so, but for the most part,
I didn't know my hand was raised. I'm sorry.
Oh, okay. No problem. So with those math problems, be sure that you're answering what it says, because sometimes it will ask the nearest whole number and sometimes it'll ask the nearest 10. So just make sure that you're answering what is being asked. So the question asked you about effective communication. And so we talked about communication being nonverbal and verbal. And so the statement that was most effective was us noticing, as a nurse, noticing that the patient wasn't doing number tasks as usual or usual tasks. And then we didn't just stop there. We asked, would you prefer something else? Which is the example that we talked about earlier. We were talking about nonverbal and verbal. The patient's head is going yes, up and down, yes, but then when I step back and assess what they're doing, it's an opposite reaction. Then, therefore, it leads us to ask those more specific questions so we can, gain more understanding and see what's going on. So we noticed the patient wasn't eating, and then we asked them if they would prefer something else. And that is the one that was most appropriate for effective communication. And we said assertive is actually like the opposite of being aggressive. Assertive, you're being honest and you are making those suggestions about what could potentially help or assist your client to manage their whatever they have going on. And so the statement that was most assertive, honest, and with a recommendation that will assist that client was saying that I believe that patient would be better if they had periods of social interaction. You encourage your clients to come out of their room or at least let the activity department know what they're interested in so that those activities can be weaved into the schedule. Of course, we have 100 patients in here, so we can't have 100 different activities every day. But for sure, there are to be some activities and options for that person to be able to interact and do the things that they like. Again, with the quizzes, you get partial points. Remember, with exams, it's all or nothing. So with the quiz, if it asks about, it was asking about active listening. So which of these responses shows that the person is actively listening? Is it the person that gives advice? What do we say about giving advice? Is that negative or positive? Is giving advice negative or positive, you all?
Negatives. We don't give advice.
You don't. That's considered as negative. So we don't, they're going to ask you, they're going to say, nurse, what would you do? Nurse, tell me what to do. We don't give advice. We can say, hey, we can get your doctor to come back and talk to you again and give you more information. We can get the dietitian to come back. We can get the therapist to come back. But we do not give advice to our patients. That's considered as negative. So, but we do allow people to speak uninterrupted. We do paraphrase what they told us, put it into our own words, just to ensure that, we're kind of making sure that what we're understanding or receive from the sender is what information they actually sent to us. And then we allow the person to ask questions to be sure that, again, to be sure that we understood them correctly. Okay, so who formulates the nursing diagnosis, the LPN or the RN?
RN.
Okay, so the RN formulates the nursing diagnosis. And with sexual harassment, is it okay for the code for anyone to make sexual jokes in the workplace?
No.
No.
Okay. And then to the Institutes of Medicine, remember, we provide patient-centered care, and that's providing that individualized, respectful care that's specific to our patients. We may have 5 patients that have diabetes, 5 patients that are in, and we could be working in a healthcare facility that's in a community, but still we're going to provide the individualized patient care that's respectful and responsive to those individual patients. We may have 5 diabetics. One may be newly diagnosed. One may have a hip fracture. One may be type 1, maybe type 2. One may be gestational. We are still provide that individualized care. And the Institutes of Medicine, again, it focuses us, it wants us to provide that patient-centered care, which is still saying individualized. Individualized or patient-centered, same thing. We're going to have to know the S bar, you all. So and you all tell me whether or not this is situation, background, assessment, recommendation. Let me see. Let me get some examples here. So we are discussing the patient's goals. What is that?
Recommendation.
Orders that need to be addressed.
Recommendation.
Okay. Procedures that must be done. Which
Recommendation.
recommendation. Okay. Let's see. We are the patient. Let's see. The patient had a dressing. Well, the dressing was changed and was changed at the wrong time. So we've already used up the equipment, the dressings, the medication, and all of that. So we're calling to report a medication error. And so what is that? Is it situation, background? Okay.
Situation.
So situation is what's going on. Is we're calling to say, explain the current situation or the issue. It could be a medication error. It could be a change in mental status. It could be the fever didn't break. The fever got higher. The blood pressure got higher. Let's see. Let's see. We're talking about, so we're doing handoff and the patient has had some type of procedure done and we are giving their vital signs. We're just going over what the vital signs are. What part of S-bar is that? And their assessment findings.
History.
So
Assessment.
Assessment.
I added that part in about assessment findings. So yes, so the assessment findings. Yes. Okay. So we gotta know this S-bar. What about if we say, okay, we're calling the doctor and the patient still has a fever, but we are telling them that we've already given them Motrin, or if the patient has diabetes and we've done a finger stick and they've already received their sliding scale insulin. And so we're just letting them know that they've already received their insulin. They've already received Motrin. What is that?
Background.
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 So we're giving that background information. Okay. So gotta know that. That's going to be heavy on your HESI and your exams. You gotta know those different parts. Okay. And we can do some more examples, up until the first exam just to make sure. Okay, and then so the question asks you, I think in reverse, about, it says, are not the responsibilities. So you read each one of them and say, is this something that this person cannot do? So make sure what the question is asking you. I think it did ask you in the reverse, because you would normally, it would say, which of these is, but it says are not. So just make sure, and I think that's where some of you I went wrong with that one. It was asking about the LPN responsibilities, but it says are not. So just make sure you're answering what the question is asking. And I don't think anyone got the teaching and learning part incorrect. All right, so are there any questions about that content? So the S bar, you got it, it's going to be heavy, heavy, heavy. Individualized care. We will talk about that, and we can go ahead and talk about it. We have a few more minutes before we go to our break. The standardized care plan, it pushes out everything about whatever it is. If it's pneumonia, if it's diabetes, if it's whatever, a left broken hip. The standardized care plan pushes out, it gives you all the options. But we have to come in. Remember, the Institute of Medicine says, hey, we need to make this patient-centered. We need to make this individualized. And so what we do is we go in and eliminate those options and things that does not apply to our patient. So a standardized care plan is not specific. It's not individualized. It does not consider the patient's preferences. A standardized care plan is every option. I'm trying to restate it and say it in different ways because we do need to know that. So we're going to enter the patient's room. So you all tell me what we do next. And this is going to take us to our break. We knock on the patient's door and we go in the room. What do we do next? We should have 4 more steps.
Introduce ourselves.
Okay. Is that right? We introduce ourselves. The nurse will identify themselves. Or we provide.
Explain what we're gonna do.
Okay.
Identify the patient also.
Okay, so we identify the patient, and then we ask them what?
Name, date of birth.
Name and date of birth.
Okay.
And what brings them to the hospital.
Okay. So we do. Of course, we do the thing now. They want the patient to see you do your hand hygiene. You got to add that in even before when you enter the room and then before you leave. They want you to do that. So we knock on the door and we provide the client our name. Hi, I am Nurse Battle, student nurse of Fortis College, Columbus campus. So that's all part of it. We kind of do them simultaneously. We provide our name and then we state, our identification. We add, what are we there for? So if we were the dietary, we knocking on the door. Hi, I am Nurse Fox. I'm here with dietary. So the first steps is after we do our hand hygiene, we'll knock on the door, hand hygiene, but then we provide the client with our name. Then we identify ourselves. And an example is I am Lily Fox from dietary. I am Lily Fox, student nurse from Columbus campus. Are you all following what I'm saying? Or is that not clear? Okay. Not seeing any left
I'm
right.
a little bit confused.
So you knock on the door and you wait to be entered until the patient tell you to come in. You do your hand hygiene. You provide the client your name and so to speak, your credentials. So and I'm just calling out a name. That's no one's name. You knock on the door, we do our hand hygiene. I am Lily Fox from dietary. I am Lily Fox, the student nurse. So we're telling them who we are, and then we are further identifying ourselves. Okay. Anyone else? Is that kind of still muddy, or did I clear that up a little bit? I am Lily Fox, physical therapy aide. So we're telling them who we're stating our name and then identifying who we are. Because they're in the hospital, they're in the long-term facility, people just come in all day. So they don't really know who we are, and then what department that we're actually from. And then we ask the client to state what?
Will it be their name and date of birth?
Their name and date of birth. And then what's that last thing? Because even though they state their name and date of birth,
Allergies.
Okay, and what else?
Allergies.
And what else?
Check the wristband if they have a wristband.
Okay, and what else? We ask them what they prefer to be called. Some want to be called Mr. and Mrs. Some want to have a nickname or whatever it is. So we're checking the name, date of birth, the allergies, and then we want to ask them, what do you want to be called? Okay. All right. And so we go on to our next break. So before we go to our next break, let me go back over that again. We knock on the door. We wait for the patient or whomever on the other side to say, come in. We do our hand hygiene. Hi, I am Lily Fox from Dietary. Hi, I'm Lily Fox from therapy. Hi, I'm Lily Fox, the student nurse. So we're telling them our name, and then we're identifying who we are. So we just add that extra piece from therapy, from dietary. Then we have them to identify themselves, state their name and date of birth, their allergies. We're looking at that name band. And then we are asking them what they prefer to be called. Okay. Any questions? All right. I'll see you in 5. Stretch here. So let's just go back over. Let's just make sure we get the rest of our content in. So let me share here. So someone, while I'm pulling this up, tell me the order. What's the order of after we knock on the patient's room? Go from there on the patient's room door.
You wait for them to tell them to enter. Wait for them to tell them to come in and do hand hygiene. Identify yourself for where you coming from. So I will be, hi, I'm Corey from nursing. I can't remember what happened after that.
Someone else pick up. What happens after that? So far, so good.
They need to identify themselves, name, date of birth, allergies.
What they prefer to be called, asked to be. Make sure you wash your hands before and after.
Mm-hmm. Good. Thank you. Great. Okay. All righty here. Let's go into these. Let's look at these different communication styles. Now we kind of started on them. Let me share my screen here. Remember, silence is good. We don't give advice. Let me share here. All right, let's see. Slideshow from current slide. So we don't want to be aggressive when we're communicating. We can, be honest and state, what the procedure is without, being disrespectful or anything. So we want to do that. Being passive, non-assertive. So assertive is being honest and stating those things, that more than likely, hey, we do, you're on a sliding scale. So that means we need you to check your glucoses. You do the finger sticks. And then if they're not wearing, the glucose monitor. And so with that will help you be able to administer the correct dose of your insulin. So that's just a conversation example. So we're being honest and we're not sugarcoating. We're not condoning them, not being them being non-compliant. We're being honest. And so passive is kind of, okay, well, you could check it if you like. But no, they really do need to check their glucoses because they shouldn't just be haphazardly pulling up medication, just administer it, just based on what they think. But it should be based on that result. So we want to just make sure that our communication is clear and honest. So non-assertive, we're kind of just fearful of that patient, because, we don't want to get them to talk about, their and it's okay. We're going to support that autonomy, but we do want to make sure that they really know that this is beneficial for them. But at the end of the day, we're going to support whatever it is, because there are sometimes patients that do not want pain medication. It is okay, but we let them know that they do have that available. We don't, act like we don't know that they have it. And aggressive is got to be careful with the lean forward with those glaring eyes. When we were talking about the eye contact, that brief eye contact, that looking away and looking back, that's okay. But that sustained leaning forward with glaring eyes, that is considered aggressive. And of course, we're not saying anything verbally, but that nonverbal communication indicates that we are being aggressive. So we want to be careful with that. Assertive, we're talking in a positive Are we taking a positive stand? We're being confident in what we're saying. We're not, doing the hand motions. We're not, getting up in their face. We're standing up straight. We're making that eye contact, and and then that, remember our space. We're not all the way in their space, because if we're in their space little grid, then that's offensive. So we want to consider that as well. Negative interactions and coping mechanisms. Projection. The individuals attribute their own weaknesses to others. Rationalization. Logical but untrue reason is offered as an excuse for the behavior. If they're not wanting to do something, we want them to say, this is just something I don't want to do. We don't want them to be making up things and saying it's why they're not doing it. In denial, the nurse can use this to excuse personal responsibility. These are negative interactions. Okay. So problem solving. We have to define the problem. So we have to gather all this information and then decide what the goal is going to be. Choose alternatives, because remember, we provide that individualized care. One size might not fit all. Then we can try those alternatives out. I talk about the fever. Sometimes we can get fever to break with Tylenol. Sometimes we have to alternate the Tylenol and the Motrin. We have to, push fluids. We have to have more than one. But our goal is for that person to be afebrile, to not have a fever. And then we want to evaluate and see if what we're doing, did it work? Is it resolved or not? Do we need to repeat? Manipulation. Feelings and needs of others are disregarded. Other people are treated as objects to fulfill the needs of the manipulator. So this is negative. Okay. Work-related issues. We talked about sexual harassment, but assault is a thing. There are many nurses that are injured by the people that they're taking care of. And it's actually a crime. And it is a real thing. So factors leading to workplace violence. Personal factors, body language, workplace practices. For example, if, I know in one area, usually they want the staff to always park farther off. And so their customers, they want them to be able to park closer up to the facility. But the parking lot where staff parks sometimes can be really, really far. And depending on the day, it's dusk going to dawn, and a dawn going to dusk. And then, where day is giving way to light. If you're having to walk in those dim lighted areas, that's potential for something to happen. Even if you have a patient that had a head injury, that may be going through detox. Sometimes they're hallucinating, seeing or hearing things that are not there. And so you have to be careful, considering that that's their safety as well as yours, because you will get injured on the job. So early signs of workplace violence: lack of cooperation with nurses and other clients and family members. So if that patient is being hostile, they're refusing care, you may want to leave alone, reapproach. If they're going through, detox, then, we want to bring all of these things. They're seeing things that are not there, hearing voices. We want to bring all of these things to the attention of the healthcare provider, because if those things are not addressed, then that's going to put us at risk, because that patient is going to more than likely not cooperate. They're going to be non-compliant because they have all these other things going on. So we want to make sure that we bring that to the attention of the healthcare provider so that can be addressed. Okay. This is just talking about the stages of violence here. Sometimes, hopefully the patient stuff belongings don't get stolen, but sometimes the staff things can get stolen. And then as a result of that, then you have a, confusion, an argument, someone confronts someone, without evidence. And then there we go. There's a violence, physical accidents and injuries. They really can occur. So we have to just make a commitment to follow the guidelines so that we can prevent workplace violence. If there are issues, go ahead and talk to someone about something. If it's, even if it's a potential, because just like the thing that I mentioned about they having us to walk in this narrowly, dimly lit area, that was just just something bad waiting to happen. mean, the truth be told, the area that we were located in, and then, you couldn't see. So what they did was that was brought to the attention of the facility, and what they did was had a ride share thing. So they would have someone that would come around every, I think it was 3 to 5 minutes, and pick you up. They still wanted you to park back there, but then they had someone that you didn't have to walk that long distance in the dark lit area. And then they extended the hours of security. So if you identify something that could potentially, lead to a problem, please bring that up. We talked about sexual harassment. Okay. Vertical, this is just talking about lateral violence occurs between, people on the healthcare team. You're working together, nurse to nurse. And then vertical, it could be those that are on the other pieces and parts of the healthcare team. Okay. That aggressive behavior. So, of course, it can result in job loss. It can result in fines and jail time if it's not addressed. So just make sure that if anything is brewing, that we bring it to the attention of the supervisor, human resources, security, all of the above. All those things, don't take anything lightly, because you just never know. Okay. And this will take us into our last few minutes here. Let's look at chapter 14. Pull it up. So the different people that's on the team. Let's see here. Who's on the team? Let me share my screen. So look at the screen and tell me if you can identify what each of, and you don't have to come off mute, but just make sure that you know what each person on the healthcare team does. We have the nurses, the nurse practitioners, the physicians, the social workers. What are those? And I do want someone to come off mute. Tell me, what does the social worker do? What do they do?
They do different things. They help patients with like placement. If they need help with Meals on Wheels, they help patients with different resources in the community.
Exactly. Thank you, Ms. Smith. Yes, exactly. That they identify all those moving parts. Because when does a discharge begin? Discharge planning begins on what?
Upon admission.
On admission. Now, those things might change. The things that we're planning on day 1 and day 2 might change by the time we get to day 10. But we should start thinking it through. Okay, this patient came in with respiratory distress or respiratory failure. They might be discharged on oxygen. We need to start thinking about getting with that social worker, identifying what resources, because more than likely that person probably doesn't have an oxygen tank or a concentrator at home. And then what kind of insurance do they have? They have to coordinate all of these things. It depends on the area you're in. There may be limited resources. There might not be a Meals on Wheels. So that social worker may know a facility, a church, a community center that does the same thing as the Meals on Wheels. They may know a health equipment company. There might be one located in the area, but there might not be. But they may know one that can deliver home supplies. If that patient is being discharged, they came in with a broken arm and they're having to do follow-up, and the doctor wants the x-ray repeated before they come back to the doctor's office. So that x-ray, we know if they go to a long-term care facility, they can actually, in our area, they drive this little, it's a van, but it's shaped kind of different. I don't want to say funny, it's shaped different. In that those technicians, they come in, they can do those x-ray, they can do a number of procedures right there in the long-term care facilities, right at the bedside. And so once that patient goes home, or that doctor comes in to see them for that next visit, they have those x-rays in hand. So that social worker has to think it through and identify all of those different resources that person may need. And then how are we going to get them? How are we going to get them? If their insurance doesn't pay, or there's some other payer sources out there. So nevertheless, we have all the different people, but everyone is just as important as the next. And so we need everyone. Everyone plays their individual role, but everyone is important. This is just talking about the different professional organizations that you can become a member of, and then most of them offer the classes, the continuing education units that you'll need anyways to keep your licensure up to date. And then a lot of them offer that special training so that you can get your certification, and then that's who you take your test through. Okay, so nursing roles and role differentiation of a care manager. So we're going to talk about this a little bit more. Those caseworkers, everyone can have one, but for the most part, they lead the case managers for those that have those multiple complex diagnoses, because just like we mentioned, all those different things and moving parts that the social worker has to work through and think through. So once that person goes home, they'll have all the things that they need. So those patients that have those usually have those more several complex chronic diseases, they for sure are assigned casework. And you, as that nurse, that's a field that you can work in. You can be a case manager, but of course you have to dial it back and go back to what's covered by the insurance. And if they don't, is there some other resource or payer source that will pay for all of these things this patient needs? And so it's a different hands-on, but nevertheless, it is still an essential role in taking care of that patient and providing that best care. We've already talked about these two words: initiates and reinforces. The RN initiates all health teachings for clients. The LPNs, we reinforce and assist with the RN health teaching as directed. Okay. This right here is just showing the different roles here. In research, we know that NIH is the National Institutes of Health. If you didn't know NIH or couldn't remember it, you should remember it now, because it's in the news since like every other day now. But the NIH is the governing part of the research, this evidence-based information that we get and we write our papers on. Is through how we get that information is through the researchers. And so we have that quantitative and that qualitative data. And then so that's where we base or cite or reference our information on. The expanded role of the LPN, as you know, we need to know that the LPN can be have a charge position in a long-term care facility, not in an acute care. They consult with available registered nurses, assist with the decision-making, care coordination of clients, assigns and supervises unlicensed personnel. So we do know that the LPN is not an independent practitioner, but we talked about those two parts where they do function more independently. We go in and do our assessment. We can give those medicine. We can do those dressing changes. We can implement. So just remember those parts. Okay. Delivery of nursing care in the acute care setting. Just talking about the total patient care, just how in the different settings of what your responsibilities are. Okay. That client-centered.
I have a question.
Mm-hmm.
So the LPN just could be a charge nurse in a long-term care facility, but the RN can be a charge nurse in long-term and acute care?
Yes.
Okay.
Mm-hmm. Yes. Client-centered relationship care philosophy. Again, just going back to providing that individualized care. Client-centered, individualized. What's another word we've used tonight that says individualized? Let's see, the Institutes of Medicine, they say patient-centered, but nevertheless, we are providing based on their preferences, their values, that individualized care. And we kind of talked about the nursing shortage. The schools, the nursing schools, the programs, they have all the different offerings now, just trying to get everybody through in licensure to help with the shortage. Then the next shortage is coming up because everyone's getting ready. A lot of people are getting ready to retire. So, and that happens in a lot of occupations where every so many years they have this huge number of people retire. And it's just based on, just how things just flow. And so you all are coming off right at the right time to help fill those nursing shortages. So important concepts. Let's read through this right here. The Institutes of Medicine defines patient-centered care as providing care that is respectful, of and responsive to individual client preferences, needs, values, and ensuring the client values got all clinical decisions. We just had this, we went over that. So, and then what else? Each member of the interprofessional healthcare team provides a valuable service. Everyone is important. We talked about the social worker, the nurse, the therapist, the dietitian. We went over those different roles. And to understand where the licensed practical nurse fits into this healthcare team, we want to be aware of the educational background, the roles and responsibilities. And you can get these different certifications depending on what settings you're in. Certain settings offer these certifications, and you can also look and prepare for some on your own. Okay. All right, I'm going to pause here. We want to be culturally competent nurses so that we can provide culturally competent care. Culture is that behavior that is learned by the members of a group and is passed down from one generation to the other. Now, as it's being passed down, it might change. We as we say, things may get tweaked a little bit, but nevertheless, it is passed down from one generation to another. It does acknowledge the view of the world in others from a similar standpoint. And so, as we provide the best care we can for our patients, we do want to learn to be flexible when our values different from our client values. We want to recognize how our culture affects our own thinking and discover how clients they're unique despite their cultural group. Even though they may be, we might have 5 patients from the same cultural group, they still are unique patients and people. And so we have to still provide that culturally competent care for them. Okay. And so as we do that, sometimes we may encounter people that have different faiths, different religions, but nevertheless, no one's culture is better than all other cultures. As a matter of fact, if someone thinks their culture or their way is better than anyone else's way, that is called ethnocentrism. And that is actually negative. And so, because there is no one way, and no one way is better than any other way. So we always have to be, we always are critically thinking. And critical thinking is outcome based. We have a patient, we're going in to take care of them. We're always thinking, well, okay, what is priority? What is the next? But critical thinking is outcome based. Okay. And so as we take care of our patients, sometimes our patients may want to include some cultural practices in their care. So it is okay to allow a person of faith, minister, bishop, or shaman, to come in and provide those rituals, just as long as it is not causing us any harm and the patient any harm. Remember that each client has an individual worth, and we just have to keep that in mind. And when we're providing that culturally competent care, everyone has that individual worth. Each person is just as valuable as the next. Sometimes we may have clients that present themselves as spiritual, and what that means is that they have deep beliefs and values that guide the decisions that they make throughout life. They think that there's they know that they have a connection with a higher power. Some of our patients, because of their cultural beliefs, may refuse or not want to take pain medication. They may link it to, past experiences, and it's okay just as long as we let them know that they have that medication available. We can't force them to take it. And to speak specifically, Buddhists believe pain and suffering are due to actions in the past or some past life. And so they may refuse or decide not to take some pain medication. If in the event that they're saying they're hurting, they still may refuse because that's their cultural belief. And this understanding that helps them because that is a belief of theirs. It will help them get through the pain. They're actually able to put up with it and refuse the pain medication and not need it because they understand, that's their understanding of why that they are in pain. While we're collaborating with the RN to decide upon interventions for our clients, we want to consider and preserve those practices that are helpful to those clients. We want to, ask them, what things have you found that help you? And if they identify things that are harmful, we want to repattern, change those harmful practices. But those practices that are helpful to them, we want to preserve those things. But the things that are not helpful to them, we want to change or repattern those. But we have to first discover the health beliefs of our clients. We have to do that, ask those specific questions when we are doing that head-to-toe assessment. We have to discover what their health beliefs are. Do they want that person of faith there? And if it is, is it a shaman? Is it a priest? Do they believe that, pain medication is not needed because the pain and the things that they're encountering is because of something that was done in the past. And we have to honor that. But how do we find these things out? Is because we interact with our clients and we discover their health beliefs.